Thank you, and thank you for invitation to do this. So we're going to be talking about hydrodynamic thrombectomy. Obviously, we all understand the benefits of mechanical thrombectomy. You know, you want to remove the clot as much as you can. The old days, we used to do thrombolysis in a lot of these patients, especially those with DVT and arterial lysis. And these patients end up in the ICU, and the risks of lytic treatment are well known, and the disadvantages of keeping these patients in-house in the ICU on thrombolytic therapy is well known, and so it would be a significant step forward. Now, this space has really improved in the past few years. There are multiple thrombectomy devices out there. Actually, at the last count, there were 42. And these are some of the contemporaries that are out there that people use. And so is the data is growing in this area also. Now, we know there are certain limitations. Some of these are first generation and trying to get improvements and things of that sort. Some have risk of hemolysis with kidney injury. There's the issue of catheter clogging with just pure aspiration by itself. Success can be quite low in patients with both DVT and arterial thrombus. Others have solved the problem by putting large devices in. And there is a price to be paid when you have a garden hose that you advance into somebody's popliteal vein and pull the clot out, and then you pat yourself in the back, say, hey, I got the clot out. Well, my response to that is da. And there are concerns, obviously, in some of these devices with patients have stents, if you work inside the stents and things of that sort. So there is currently no perfect device really out there. So we want to introduce you to the hydrodynamic thrombectomy system, which is the JEDI. It is a peripheral thrombectomy system. Now, some of the unique features of this include the fact that there is a jet that injects inside the catheter, so that it prevents that lollipopping effect or catheter clogging that frequently happens with pure aspiration. That breaks up the clot and pulls it inside, and we'll show you some videos of that. And one of the other advantages is that the hemolysis, that if it occurs when you break down the cells of the clot, is not in the vessel. It's actually inside the catheter and pulled in. So the probability of hemoglobinuria is actually quite low. We haven't seen any. The system's out there. You guys can introduce yourself too. This is how it works schematically, and we'll show you real cases in a second. So the jet is turned on. And as the jet turned on and you advance the catheter to engage the clot, and the tip of the catheter has to engage the clot, obviously, for it to work. And as you pull the clot in, it's broken up and pulled inside. So you may say, well, this is just the schematic. Here's a Play-Doh, and this is how it works. As you can see, once the tip is engaged, boom, the whole thing is pulled in, and it works beautifully nicely. So this is a study that was actually done in Boston and published already, of 3 different devices on a benchtop model. And as you can see, look at the difference. These are pectoral catheter maceration and ballooning and things of that. So we know none of that work for really flesh clot. But I want to draw your attention to the curve over here. The time it takes for JEDI was about 8 seconds for this clot model. The Indigo system took 2 minutes. Aspirex took 8 minutes. And these are the 3 devices that were actually tested in this system. And here's an example. If you look at it, this is side by side. This is the JEDI. This is the AngioJet, the Zolante 8-French catheter. This is not a speeded up. This is what actually you see. And a lot of this is clot is pulled not as completely as that, but also, obviously, the issue with Zolante is the hemolysis that you get as you pull. And here's the comparison to this is the 12 French Lightning penumbra catheter, the Indigo. This is the 8 French JEDI, same volume and diameter of the clot. And this is what we have seen in patients also, and I'll show you examples, both arterial and venous. And this, most of this, the reason for that is the mechanism that we talked about, and that jet inside of that catheter that breaks up the clot, so the clogging like this does not happen. Here's, I think I did this many, many years ago. This is a 10 millimeter lumen with fresh clot in there, and we're advancing this, and the directionality is provided by the sheath, and the tip of the Jedi catheter is just slightly past the sheath, and we advance both of them together. And this is how fast it works. Okay, well, let's see on the arterial side. This was a study that was done by Dr. Onofre. Now we have our own experience that we're going to put in the literature pretty soon. Here's a fresh clot, acute thrombus in proximal SFA. And what they looked at, their study included the definitions of their endpoint, as mentioned here. And here's what they saw. Jedi alone was successful in 26% of these patients. That's all they needed in patients with acute limb ischemia. Jedi and adjunctive procedures, about more than half of these. And arterial system, as you know, there's always an underlying lesion. I'm surprised that 26% were sufficient with Jedi alone. And overall, 85% success rate in this study. So let's look at some of these cases. This is a 51-year-old, actually this is from us, male with history of left fem to below the knee bypass, using PTFE in January 2016. This had failed a couple of times. This is a patient who had had multiple endovascular interventions, all failed, and the bypasses had failed, and now we have a synthetic bypass. The graft failed in 2016 and underwent successful thrombolysis. It was just TPA overnight infusion. It was treated with Coumadin. 1 year later, he presents with coolness of the foot, and here's what it looks like. And you can see that here's the previous stents that had been placed, and the trifurcation has been reconstructed also with drug-eluting stents down here. And here's the native SFA, and it occludes right above here, and here's the beginning of the bypass. Now, when you have a synthetic bypass, when you put this device in there, you don't even have to advance it. It's been our experience that when you get halfway through it, it actually sucks the entire thing in as powerful as it is. And this couple of passes later, and here's what it looks like. And this is the synthetic bypass just on the table a few minutes later. Very powerful system. Here's a patient with 85-year-old atrial fibrillation, acute lower extremity pain. Patient has cold foot. The ABI is 0.4. And here's what the angiogram looks like. You all would recognize thrombus sitting here. This is a patient that in the old days we used to treat with thrombolysis. Put the catheter in there, but this is an 85-year-old with patient with hypertension and diabetes that you know that increases risk of intracranial bleed. So this was actually treated with Jedi, and here's our sheath sitting right up there, upstream from the clot here and the thrombus here. You can see there's the anterior tibial reconstitution, the perineal. We don't even see a posterior tibial. So our objective was to reestablish flow in the perineal artery and get the patient back to the baseline, because as you can see, there was some, looked like evidence of chronic disease in the anterior tibial artery. Posterior tibial, we don't know what the status is. There may be fresh clot, there may be chronic, but we know the perineal will probably keep the foot alive. So objective was to clean the clot here, clean the clot right up here, get flow into the perineal, and see how the patient does. And so this is live going down. As you can see, here's the tip of our sheath, here's the tip of the catheter, and this is the speed with which we advance it. Here it is, coming down. Okay, and this is over 014. We're using a 6 French 035 over an 014 system. So on the arterial side, we don't usually want to give up our access. And then this continues into the tibia perineal trunk. And the wire went into the posterior tibial, so I took it. And so we advanced this thing into the posterior tibial. And 2 passes later, this is what we got. And you can see the fresh in the clot in the posterior tibial actually was, the occlusion was fresh. So we pulled it out. The clot at the trifurcation is gone. This clot is gone. Now we can see the underlying lesion. So that underlying lesion was balloon dilated, and we put a supera in there, and we got actually 2-vessel runoff. Now, after this, we went after that, the anterior tibial artery also was a chronic occlusion. We went ballooned up, and we got 3-vessel runoff in this patient. 99-year-old female, long-standing peripheral arterial disease, had right lower extremity ischemia due from post-SFA stent. Now, non-invasive studies shows 0 toe pressure and 0 ABI. 99-year-old, 85-year-old, you don't want to put them on thrombolysis. These need to be treated on the table. And here's the inside the stent was occluded. So what we did, this is the initial angiogram. We used actually the 6-French cat thrombectomy devices at the Indigo system, and went all the way down to the trifurcation. This is what we got after Cat 6. Didn't work that well. And so at this point, we switched to the Jedi and pushed the Jedi one pass, and here you go. And this sort of parallels those videos that you saw of the comparison between the Indigo system and the Jedi system. This was another one that we treated Indigo on first. Complicated history, patient has had multiple interventions, this, that, and the other, everything's thrombosed. So after we declotted the SFA and stented it, is stented all the way up to here. The issue that I want to show you is the profunda. The profunda is out, and my stent right up there was flowering into the profunda, so it made it difficult over 014 to advance larger catheters in there. So we tried with the CAT RX. Those of you who are familiar with CAT RX, you know that it's an 014 system that actually works really well for below the knee. And we tried it and it didn't work. And so I put the sheath in there and put our Jedi in there, and one aspiration, the entire thing was evacuated. Let's show you a few venous cases. Same thing. And this was a prospective pilot study done at our center. We looked at 52 limbs, 53 limbs in 47 patients, all with iliocaval. It wasn't just iliofemoral, iliocaval DVT. And here's what we saw. Iliocaval, the flow restoration by Jedi alone, numbers are here. And this is what we got after stent placement. Most of these patients obviously get stented. Those of you who are familiar with the venous thrombosis space, you would recognize that these are very, very high numbers. To be able to get this kind of number in patients with DVT is actually quite remarkable. Let's show you a couple of cases. Here's a patient, case 1, single session treatment. Now, DVT, treating them with single session has really been the holy grail of management of clot in these patients. Access into a popliteal vein, as you can see, everything's thrombosed. A very typical duplicated femoral venous system. And you can see that the clot all the way into the external, and the iliac and typical May-Thurner iliac vein compression system. Those of you who do chronic iliac reconstructions or maybe new to this, I want to caution you that there are plenty of collaterals from especially the iliacs and the common iliacs into the epidural plexus. So as you're recanalizing and you go into someplace out here and you think it's IVC, make sure you inject a little contrast and ensure that you are in IVC. You could easily be in the spine. And it would be disastrous if you put balloons in there. So don't do that. This has happened. It's been in the literature. Just as an aside, as a tangent, I show you. So now everything is clotted in this lady. Here's a live case that we're going to show you. The system is in, as you can see now in the venous system, since we're coming from the pop and in the direction of valves, I don't use wire. We take the wire out, so that increases the aspiration power of the system. And here it is. You can turn it on, and immediately you can see clot just pulled in. Even the clot from the parallel vein is being pulled in. You can see all the clot is sitting up here and into the profunda. And typical radiologic features of a fresh clot. And let's take a look at that. We turn it on. Boom. You can see the clot is being pulled in as we advance it, and we go wall to wall. This is after a couple of passes. You can see both channels are cleared, and common iliac, common femoral, the profunda, the femoral vein, and the external iliac vein, but there's no flow because we have an obstruction out there. Now you have to go ahead and angioplasty and stent that, and that's what we did. And here it is post, very brisk flow. And here's the outflow after angioplasty. Now what I do want to show you is this. This is when we started, okay? Note the time is 10:20 a.m., okay? This is our initial venogram angiogram that we did with everything clot. Here's our completion. Note the time, just over an hour. Entire iliofemoral segment declotted in over an hour. This is something that we have not been able to do. These patients used to go on thrombolysis overnight, 2 days sometimes. A different case, 17-year-old female, factor V Leiden protein CNS deficiency. These are the patients who are set up, has had multiple work done, somewhat non-compliant patient, doesn't want to take injections of Lovenox, and rethrombosed everything. And here's what the venograms look like. And this was also treated, and you can see here it is, down from the popliteal. This was somewhat of an organized clot in there, as you can see, and so these were pulled in. Same thing here. As soon as you turn it on, you can see it evacuates the vein. Now, what I want to show you here is now, at this point, we don't have an outflow yet. We have not opened up, and our inflow is limited. When we turn it on, look what happens to the stent. You see that? This is how we know we evacuated the entire content of that segment. And that's why in a synthetic bypass, when you put this into a FemPop bypass and turn it on from the proximal segment, it's going to evacuate the entire thing. It's a very powerful system. By the same token, remember, if you put the tip of this thing in the flowing blood, you're going to get blood out. The tip of this thing has to engage the clot. So here it is after a few passes. Now you can see there's some chronic components in there that needs to be obviously angioplasted and relined, and everything looks clean, again, with a single session. Last case, I'm going to show you this patient, a 73-year-old obese, status post-fall on a horseback, had multiple injuries, had spine surgery, and had a prophylactic filter placed and had a DVT which embolized into the filter, and his entire IVC in both legs thrombosed, and now he's in phlegmasia on both legs, and you can see he's already had fasciotomy on that side already. And these are injuries from his horseback, it's not from his DVT. But so now we have, in the past, this patient used to go to surgical embolectomy, because he's phlegmasia on both sides. We can't use anything that would cause, by the way, his eGFR was not very good, so we don't want to use anything that may impact kidney function, so we decided to use Jedi in this case. What I want to show you is we cleaned up the legs just like you just saw. Here's what the clot and the filter looks like. Below that, everything was clotted. So we started with the Jedi on both sides, started cleaning things out. And this is our technique in the filter. You can go from side to side, and you're using a curved catheter to go from wall to wall and clean everything out. And here's on-the-table flow. Little bit of residual clot in the filter, but on-the-table flow. So even in the setting of phlegmasia, we can do these very rapidly. Couple of cases on the upper extremity. Now, for the upper extremity, we use 6 French. You don't need to use the 8 French, because 6 French does a great job. As you can see, patient has had DVT. Patient has had multiple catheterizations from the left IJ to the left brachiocephalic vein, is chronically occluded, and developed thrombus. This is typical fresh thrombus in the vein. And this was treated 1 pass of the 6 French Jedi. Everything is evacuated. Some residual clot. Some more out here. And you can see this segment is now clean. and some residual clot in there that we passed the GEDI. Now we have even we pulled the clot out of the IJ. All of that is cleaned out. Now we have obviously the chronically occluded brachycephalic that we have to angioplasty and stent that we do. So these are a few examples just to show you guys the power and the advantages of this system. There are some data out there that we just talked about, and some more will be added on the arterial side in the literature soon. So I'm going to stop there, and if you have any questions, be happy to answer. Thank you.